Good morning, everybody. I'm Victoria Lancy, the Rural Education Manager with Michigan Center for Rural Health, and I would like to welcome everybody to the MACRA MIPS and APM's education series. Our topic this month is understanding the MIPS cost category, and I would just like to welcome to everybody to today's webinar portion. Just to remind everybody, this is a recording and it will be posted on the MCRH website, and we can also post our slides there for you too. If you have any questions, you can email our presenters and then they will follow up with you. Thank you, and we'll hand it over to our speakers, Lisa Lusudo from Hall, Render, Killian, Heath, and Lyman. Go ahead and take it away, Lisa.
Thank you so much, Victoria, and thank you everyone for joining me for our webinar series today. This morning we will be talking about understanding the MIPS cost category. This is going to be a review for some of you who joined us in September on this topic, and for those of you who are just joining us today, we're going to provide you with a high-level overview and review of the cost category requirements. We'll first start out by talking about some of the cost category cost measures. We'll then discuss how data is submitted and collected for the cost category. We'll also discuss how this performance category is scored by CMS, and we'll walk through some practical examples of scoring. And then finally, we'll conclude the webinar with discussing some tips for how you are able to maximize points in this performance category. So to set the background, and just as a reminder and refresher for those of you who are familiar with the MIPS program, and for those of you who are not, this slide details how the MIPS performance categories are broken out by CMS. So as you can see, there are 4 performance categories for MIPS reporting year 2018. You are eligible to earn 100 possible MIPS final score points in the MIPS program. And each category is assigned a specific weight. And as you can see from the slide here, the cost performance category is worth 10 points or 10% of your MIPS overall score. And depending on how well you do across all of the performance categories will depend on whether you are eligible to receive a positive, negative, or neutral payment adjustment to your Medicare Part B professional payments for 2020. So for some background, for those of you not familiar with the cost category, the cost performance category essentially replaced the value-based payment modifier program under PQRS. In 2017, CMS did not score this performance category, so the maximum score for cost was 0 points, and the cost performance score actually accounted for 0% of your overall MIPS final score. So CMS did collect data on costs in 2017, but providers were not actually scored on this performance measure. However, for the 2018 performance year, the cost category is scored. So now this particular performance category has a maximum score of 10 points, and it will account for 10% of your MIPS final score. It's important to note for those of you who may be participating in MIPS as a MIPS APM, cost will continue to account for 0% of your MIPS final score, and CMS hasn't changed MIPS APM scoring standard for cost for the 2018 performance year. Just something to keep in mind for those of you who are performing as MIPS APMs in the MIPS program. It's also important to note that this performance category is evaluated over a 12-month reporting period. And just to remind you that the reporting period for the 2018 MIPS program year started on January 1st, 2018 and ran through December 31st, 2018. So for performance years 2019, 2020, 21, and beyond, CMS will establish the weight of the cost category in final rulemaking. So for this performance year, the cost category is worth 10%, but that may increase in future reporting years. Due to statutory changes made in the Bipartisan Budget Act of 2018, the weight assigned to the cost performance category must be between 10 to 30% in the 3rd, 4th, and 5th years of MIPS. In fact, for performance year 2019, the cost category is worth 15% of your final MIPS score. So as you can see, cost will slowly start to potentially increase over time the further along we go in MIPS reporting years. So what data does CMS use for cost scores? How does CMS assess your data and score you on cost? So it's very easy and straightforward. CMS will use data from your Medicare Part A and Part B claims with dates of service from January 1, 2018 to December 31st, 2018. You might be happy to find out that you don't need to take any additional or separate actions or submit anything special to report on this MIPS performance category. All you need to do is to continue to see your patients as usual and submit your Medicare Part A and Part B claims. So very straightforward, very easy, as opposed to some of the other MIPS performance categories. There's nothing additional that you need to do in order to submit. There's no special or additional data submission mechanisms for this performance category. All you need to do is to continue to see your patients in the normal course of business and submit your Medicare Part A or Part B claims as usual. So CMS will evaluate your cost data by using your individual NPI and group payer tax ID numbers. So individual clinicians will be identified by their unique tax ID or NPI. And there are two separate cost measures that CMS will evaluate you on for the 2018 performance year. And those are known as the Medicare spending per beneficiary cost measure. And the second cost measure is known as the total per capita cost, or TPCC measure for all attributed beneficiaries. And we'll discuss each of the cost measures in greater detail in the next few slides. So the first measure we'll talk about is the total per capita cost measure. This cost measure is calculated from all of your Medicare Part A and Part B claims during the MIPS performance period. Again, that's January 1, 2018 through December 31st, 2018. On patients that are attributed to a clinician or tax ID. Patients will only be attributed to one clinician or tax ID using the level of primary care services that were received and the clinician specialty that performed the services. A little bit different than the total per capita cost is the Medicare spending per beneficiary cost measure. And this cost measure is calculated based on what Medicare pays for services performed by an individual clinician or tax ID during a Medicare spending per beneficiary episode. So a little bit different than total per capita cost. This cost measure is evaluated based on an episode where as the total per capita cost measure is evaluated during the entire performance period. A beneficiary episode will include a period of 3 days leading up to an index admission, which we'll talk about a little further. Cost is evaluated during that entire episode and will also include the period 30 days after a post-hospital stay. So after discharge, the 30-day period following discharge, all of those claims will be accounted for and evaluated as well and will count towards the episode. So let's dig a little deeper on the MSPB cost measure. CMS uses MSPB to assess the cost of Medicare Part A and Part B claims during an episode. Again, as I previously mentioned, that will be evaluated based on the 3-day period immediately before, the period during, and that 30-day period after a patient's hospital stay. An episode is defined by CMS to include Medicare Part A and Part B claims falling in the episode window. Again, an MSPB episode will span the dates 3 days before an index admission to 30 days after a hospital discharge. So all of the costs that are accrued during that period will be evaluated. An IPPS, or Inpatient Prospective Payment System, hospital admission will trigger an episode, and these IPPS hospital admissions are called index admissions. So this slide visually details where an MSPB episode will start and where it will end. Again, as you can see, that 3-day window prior to an admission will count. All of the claims that are accrued, Part A and Part B claims, during an index admission and following 30 days after the beneficiary's discharge from the hospital admission will all count in the window of the episode. So all Medicare Part A and Part B claims for items and services provided to the beneficiary during the episode window are included in an MSPB episode. And here are some following claim types that will be included within that window. Inpatient hospital claim types, any outpatient services that the beneficiary receives, skilled nursing facility services, home health and hospice services, as well as DME equipment will also be counted, and non-institutional physician or supplier claims. So additional Part B professional services will also be included in the episode window. A key factor of MSPB cost evaluation is known as attribution. So for MSPB, CMS will attribute each episode to the clinician who provided the most Part B services in terms of the dollar amount of Medicare allowed charges during the index admission. In the case of a tie between two providers, an episode will be attributed to the clinician who has the highest count of Part B services. CMS will attribute episodes at the individual clinician level via the clinician's tax ID or NPI. However, those who participate in MIPS as groups will have a single score for their group based on the combined data. An additional key factor to the MSPB cost measure is meeting the case minimum threshold. So you'll have to meet at least 35 episodes attributed to you in order to be scored on the MSPB cost measure. You will not be scored on MSPB if you have fewer than 34 episodes attributed to you, or if you did not bill Part B services in hospital stays during the performance period. So this slide is more for informational purposes and contains a lot of detail. I won't go through every single bullet point here, but it's just here for you to reference back to be aware that there are certain beneficiaries who will be excluded from the MSPB measure when evaluating the MSPB cost measure. So for example, if a beneficiary passed away during the episode, that beneficiary will be excluded, as well as, for example, if a beneficiary was not continuously enrolled in both Medicare Parts A and Part B from 93 days prior to the index admission, that beneficiary would also be excluded. So again, just important to note, there will be beneficiaries who may fall outside of the window, and again, feel free to reference back to the slide so you can see what all of the MSPB exclusions are. Here's a comprehensive list for you on this slide. So the second measure is known as the total per capita cost, or TPCC measure, that CMS will use to evaluate your cost. CMS will use the total per capita cost measure to measure all of your Medicare Part A and Part B costs during the MIPS performance period. Again, this is during the entire period between January 1 through December 31st, 2018. For the TPCC measure, beneficiaries are assigned to a single Medicare Clinician Tax ID NPI in a two-step process that will consider the level of primary care services the beneficiary received as measured by Medicare allowed charges during the performance period, and the clinician specialties that perform these services. A key factor to the TPCC measure is attribution, again, similar to MSPB. TPCC assesses all Medicare Part A and Part B claims, and for this measure, attribution is a two-step process. So CMS will attribute a beneficiary to the tax ID NPI who provided the most primary care services based on allowed charge amount from primary care physicians, NPs, PAs, or clinical nurse specialists. If a beneficiary is not attributed in step one of the process, CMS will attribute a beneficiary to the tax ID NPI who provided the most primary care services based on allowed charge amount from non-primary care specialists. And CMS will define primary care services to include E&M services that are furnished in an office setting and other inpatient settings, non-ED settings, as well as initial Medicare visits and annual wellness visits. Those are also included in the definition of primary care services. Again, attribution is another key factor for the TPCC measure. So beneficiaries who do not receive any primary care services will not be attributed. And in the case of a tie, an episode will be attributed to the clinician who most recently provided services in cases where two clinicians are tied. There is also a case minimum requirement to the total per capita cost measure. So in order to be scored on the TPCC measure, eligible clinicians and groups must have at least 20 different episodes attributed to them. Clinicians and groups with 19 or fewer episodes attributed to them will not be scored on the TPCC measure. So it's very important that you're aware of the case minimum requirements in order to be scored. And again, just a friendly reminder and tip, you don't need to do anything separate or special to submit your data and evaluate the reports in the cost performance category. Just continue to see your patients as usual and submit your Medicare Part A and Part B claims, and CMS will collect that data and will be able to score you based on those claim submissions. So similar to MSPB, there are also Medicare beneficiary exclusions associated with the TPCC measure. So beneficiaries who are not enrolled in both Medicare Part A and Part B for every month during the performance period will be excluded unless part year enrollment was the result of new enrollment or death of the beneficiary. Additionally, beneficiaries who were enrolled in a private Medicare health plan for any month during the performance period will be excluded as well. And if a beneficiary had resided outside of the United States during any month of the performance period will also be excluded. So as I mentioned, both MSPB and TPCC have these case minimum thresholds that are very important for purposes of scoring. If you do not meet either case minimum threshold, your performance score on cost will count towards 0 of your overall MIPS final score. And what will essentially happen then is CMS will shift the weight to your quality score. So essentially, your quality score will count for 60% instead of 50% of your overall MIPS final score. So it's important to always keep in mind, quality is very important in addition to cost. And so please also focus on ensuring that you're paying attention to quality and doing as well as you can in the quality performance category as well. In the event you don't meet either of these case minimums for cost, your quality score will count for a bigger piece of the pie of your overall MIPS final score. So how is the cost category scored? So essentially each individual MIPS eligible clinician and group's cost performance will be calculated using administrative claims data. Individual MIPS eligible clinicians and groups are not required to submit any additional information, as I mentioned, for the cost performance category. So this is just based on your administrative claims data for reporting. Very easy, very simple, very straightforward. Unlike some of the other MIPS categories, you essentially don't have to do anything extra. You don't even have to think about it. Just continue to see your patients and ensure that your claims are submitted in the normal course of business. So how is the cost category scored? CMS will establish national benchmarks for each cost measure. These benchmarks are based on the performance period and not on a historical baseline period. So as a result, CMS can't publish the actual numerical benchmarks for the cost measures before the start of each performance period. So unfortunately, you won't be able to know what the benchmark is before the performance period begins. So for example, the MSPB benchmark used to determine a MIPS eligible clinician's 2018 cost performance category score will be based on calendar year 2018 claims data. So it happens in real time. All MIPS eligible clinicians that meet or exceed the case minimum for a cost measure are included in the same benchmark. So you're basically evaluated against all of the other similarly situated MIPS eligible clinicians. So your performance will be compared against performance of other MIPS eligible clinicians and groups during the 2018 performance period. To calculate a 2018 MIPS performance period cost performance category score, CMS will assign a 1 to 10 achievement points to each scored measure based on the individual or group's performance on the measure compared to the performance period benchmark. So again, as I mentioned, you will see that cost is evaluated based on 1 to 10 achievement points that you could potentially earn that are assigned to each measure based on your performance. And it's also important to note that measures are risk adjusted to account for differences in beneficiary level risk that can affect medical costs no matter the quality of care provided. This is very important for those of you who are providers that have chronically ill patients. CMS will account for that. So just not to worry, in the event you just so happen to have chronically ill patients that may happen to be in and out of inpatient hospital stays, CMS will account for that. So for determining your overall cost performance, CMS will average your achievement points based on the two measures. So cost performance will equal the total points scored on each measure divided by the total possible points that are available. So we'll walk through a quick example here. This is pretty tricky, so just to kind of break this down and understanding how this works. So say, for example, you have 20 episodes that are attributed to you for the MSPB measure and 20 episodes that are attributed to you under the TPCC measure. Which, if any, cost measures would your score include? Again, to remind you, both the MSPB and TPCC scores count, and it's the average that will help you result in getting your overall cost category score. So here in this example, your score would only include the TPCC measure because you're below the 35 case minimum for being scored on the MSPB, but you're at the 20 case minimum for being scored on TPCC. So even though you didn't meet the case minimum requirement for MSPB cost measure, you can still be scored on the cost performance category because you at least met the case minimum for being scored on TPCC. So for purposes of this slide, for this particular example, we're going to assume that both case minimums were met for each measure. So as you can see for this particular provider for the TPCC measure, they achieved 8.2 out of the 10 possible achievement points based on their claims data. And for the MSPB measure, they achieved 6.4 out of 10 possible achievement points. So when we add that up, that's a total of 14.6 measure achievement points out of the 20 possible achievement points this particular provider could achieve. So 14.6 out of the 20 possible points is 73%, or 7.3 points towards your MIPS final score. So this clinician will earn a score of 7.3 points out of 10 points in this particular performance category. So I just want to point out and remind everyone that beneficiary level data is not available for the cost measures in the 2017 performance feedback, and CMS is currently unable to provide it. So this is just a note from CMS that I wanted to point out to everyone. And feedback on 2018 performance period cost measure performance will be available sometime in summer of 2019, and CMS is looking to incorporate beneficiary level data if technically feasible. So here are some key takeaways for you to think about as it relates to the cost category. So please keep in mind that the cost category is comprised of the average of your MSPB and TCCP measures. So if you're unable to meet the case minimum or requisite requirements for one measure, that's okay because you still could be scored on the other measure. MSPB measures require the clinician or tax ID to meet the case minimum with at least 35 reported episodes. And again, as a reminder, the TPCC measure will require you to meet the case minimum of at least 20 reported episodes. So those case minimum thresholds are very important. If case requirements are not met, the cost category is reweighted to 0% of your overall MIPS final score. And again, your quality category will increase to 60% of your MIPS score instead of that 50%. So your quality category weight will just go up. So here are some practical tips for you to maximize points in this performance category. Again, all you need to do is see your patients as usual and submit your claims as usual. There's no additional data that's required to be submitted for the cost category. So this is probably the easiest MIPS performance category for you in terms of, from an administrative perspective, there's nothing additional that you need to do. We suggest that you consider hiring a care coordinator to help you contain costs. This might be a good way for you to ensure that your costs are managed as best as they possibly can. And a care coordinator could also help you in terms of ensuring quality outcomes. So Again, just a consideration if this makes sense for your practice from a financial standpoint. This may help you in terms of managing your costs and ensuring good patient quality outcomes. We recommend that you document your complex cases. So remember that CMS will adjust scores for risk to account for differences in beneficiary level of risk that can affect quality outcomes or costs. So for chronically ill patients and for patients that have a complex medical background, we recommend that you document that very accurately. This will enable more accurate comparisons across clinicians and groups that treat levels of varying clinical complexity. And again, remember, CMS will adjust for health and other risk factors that affect outcomes that are beyond clinicians' control. So CMS does recognize that, some of you may have chronically ill patient populations with complex medical backgrounds that, may result in those patients needing inpatient hospital stays or, post-acute care. CMS will account for that. So make sure that you're documenting very accurately those complex cases. We also recommend that you be sure that your ICD-10 coding and other documentation thoroughly detail clinical complexity of the diagnoses that you're treating. Again, for that same reason that CMS will adjust for health and other risk factors for those clinically complex patients. We also recommend that you avoid, when feasible, unspecified or uncomplicated ICD-10 diagnosis codes if your medical record documentation supports the more complex codes. So very important, especially because CMS is only going off of your claims data here, that your documentation is accurate and that your claims are very accurate. Some other additional considerations for maximizing points in this performance category is review your performance feedback. Even though CMS didn't count the cost towards your final MIPS score in 2017, CMS does provide feedback on your 2017 cost performance if you did meet the attribution threshold for MSPB, TPCC, or both. So review some of the resources that CMS has provided on this measure. And you may have already been getting feedback from several years on cost measures from the Physician Feedback Program Quality and Use Reports, or QRURs. So you may want to review those reports as well to kind of get an idea of how well you might do in this performance category for 2018 based on your 2017 outcomes. So as we are approaching some key deadlines, I wanted to lay these out for you, some reminders for the 2018 MIPS reporting year. The submission window is currently open through April 2nd, 2018, and will close at 8 p.m. for reporting year 2018 on this date. So very important to note that the submission window is still open for submitting your MIPS data for performance year 2018. April will be here before you know it, so just wanted to let you know and remind you of that. And also the CMS web interface submission period will end on March 22nd at 8 p.m. So just please keep that in mind as well. I've provided some resources from CMS for you in case you need additional help navigating the QPP program and MIPS submission. There's some phone numbers there for your reference. And that's it for today. In March, we're going to talk about a review of the MIPS program for the 2019 reporting year, because now, before you know it, we're already into the 2019 reporting year. So we're going to talk about some of the changes upcoming for 2019 to the MIPS program and how to navigate some of those changes. And please feel free to email Brian Bauer or I if you have any additional questions. Our email addresses are provided here for you for your reference, as well as our phone numbers. And with that, I would just like to thank you all for joining me today.